a very nice, great hospital. One of the emergency room doctors was seeing a patient, and this was a little boy who came with a ear infection, and he gave the medication, antibiotic, and he documented, and the patient was discharged. Patient went to a different hospital, and after a few days, this case became a published one. And the doctor who actually see that patient in the emergency room lost his license. You know why he lost his license? He just taken the history, which is fantastic. Everything was to the point. But he mentions one thing. The child is crying and cranky. Child is crying and cranky. And you know what? If you look at the Nelson's textbook of medicine, if a child is crying and cranky, it could be meningitis. Alright? Now, what was their mistake was, in the documentation, there was no need, because the history and reporting is two different type of things. When you take a history, you are not writing anything that has no relevancy. If there is a relevancy, then you have to justify what is that relevancy all about. If you cannot justify, do not throw a word that has no meaning. Am I getting across what my thought is? So, he did not do neck rigidity examinations, he did not do cardiac sign or Brzezinski. So, actually, he was defending vigorously in the court that no, there was no evidence of meningitis on that patient. Dear doctors, that is not enough. If you have not written that, it does not exist. It didn't happen. You see? So that's why a documentation is extremely important, and at the same time, how to do the right coding. Dr. Justin Singh is a clinical psychiatry doctor in the Larkin Hospital, and we will be available to help or any questions as a panel. Dr. Mojibur Mojumdar, you know him, he is the Pulmonary Hypertension Program Director of the Brookdale University Hospital, and he will be available, and Gerardo Ferrar, he is the Program Director of the Psychiatry Residency at Larkin Hospital. Please give a round of applause and welcome Dr. Justin Singh.
Good morning, everyone. So I believe I have the most difficult job for this whole 3 days that we've been here, which is to try to keep you awake to talk about billing, coding, and documentation. Doctors tend to be more analytic. They tend to be, they want to get more information from the patients. They want to know the story. The documentation side is the pain in our butts. It's the side that increases our risk for burnout. There's a lot more stresses in it. Understanding the way that the system works from the front desk to the clinical staff that accepts the patient and that evaluates the patient, the doctor who sees the patient, and then the coders and billers who have to take that information and then get us paid. It's really important to see the whole picture, and that way, from the front side, we can document adequately so that we make sure that we're the most efficient in our billing and coding. Okay, so some of our learning objectives, we're going to identify key terminology in billing and coding, identify procedure coding, diagnostic coding, and evaluation and management codes, also called E&M codes. We're going to look at the guidelines and review diagnostic codes specific for sleep medicine. We're also going to explain the information that's required to complete insurance claims, the review process, and explain appeals and the rebilling process. Okay, so documentation is what all of the billers and the coders use to identify specific codes that relate to what is happening with the patient. These are diagnostic codes, every diagnosis that the patient has, procedure codes, the office visit, and any sort of diagnostics that you want to do, like a sleep study. So it's really important for adequate documentation so that the coding is appropriate and right, so that the insurance companies don't bug us with denials. We obtain reimbursements from the insurance companies, but also categorizing based off of a standardized criteria in ICD codes and CPT codes helps Medicare, Medicaid track and trend some of the diseases that are evolving over time, so we can adequately allocate resources to those specific places. So it helps us to understand and leads to statistics on diseases and health conditions. So, as I mentioned, there's three types of codes. There's procedure codes, diagnostic codes, and E&M codes. Codes for procedures like sleep tests, diagnostic codes for the patient's condition, and then procedure codes, which are most frequently used in sleep centers, and they typically bill for office visits. So codes exist for new patients, they exist for established patients. They vary based off of the intensity of the service that's provided, and they're very diverse. Codes are standardized across the board. So hospitals, nursing facilities, and ER room visits all have their own specific E&M codes. Modifiers exist. The modifiers exist because if the service that is provided doesn't exactly meet the guidelines and criteria that is outlined in the ICD or in the CPT, then the modifiers are there. The most important one not ever to do is 52. 52 is a reduced service modifier. It means that typically a sleep study, in order for it to be full service, it has to be done for at least 6 hours. If it's done for less than 6 hours, the 52 modifier needs to be used. What does that mean? Insurance is going to pay us less. It becomes difficult with the modifiers as well, because if they don't, they might pay us less, they might not pay us at all for the service that's rendered, dependent on the insurance companies. There's a lot of variation, and so it's important to know which insurance companies cover what. And so also when we do the claims, most of the claims are done online. Claims are a way where the provider communicates with the insurance company and the services, about the services that are provided so that they can be reimbursed. All right, so staff roles. It starts with the front desk. The front staff office is responsible for booking appointments, to book the appropriate amount of time for the patient to have an appropriate evaluation. They're also collecting a lot of data from the patient. All of their information in terms of their name, their date of birth, age, sex, the insurance that they specifically have, the group policy numbers. Then there's the clinical and professional staff who will evaluate the patient based off our identifiable data, our blood pressure, oxygen saturation, the physical exam, the history of physical. And then the coders and billers are at the end of this role, where they take all of the documentation that we provide them with, and they try to make sense of which codes are going to be able to be used in order to get the most reimbursement, the most appropriate reimbursement. So as I mentioned, the front desk is responsible for scheduling, registration, ensuring that the insurance information is current, and that there's the proper spelling for all of the people's names, date of birth, and the policy numbers. Clinical and professional staff, they're responsible for assigning the codes based off of the service rendered. They're usually entered into the EMR, and a super bill is created. So before we had EMRs, typically every patient would have a piece of paper. The piece of paper would have the most common codes that the sleep center or the family medicine clinic would bill for. And And then the doctor, after evaluating the patient, would look, check off all the necessary codes that needed to be checked off, and then the billing and coding staff would take that super bill, use the documentation, melt the two together to see which codes actually will be billed for and paid out. The coding and billing staff, they confirm the codes that are assigned by the clinical and professional staff. They submit the claims, they interact with the insurance companies, they obtain the reimbursements, and then they fight for us when we get denials. So, I believe that the coders and billers, they have the most difficult job because they're at the end of the spectrum where they've received the information after the patient has already left. There's no way to collect the data in this element. So it's really important, the coders and billers, they're challenged with having the most accurate information and the most detailed information that they can have. So they have to constantly question the accuracy of the staff at the front desk to avoid any sorts of errors that are there. They also have to question the accuracy of the clinical staff and emphasize the importance of avoiding code errors. Sometimes if a code is being used and it has specific guidelines under that code that were not documented, then likely that code is going to result in a denial or an appeal. So coders and billers, they're responsible for a wide variety of tasks which are critical to the financial viability of the practice. So how have things changed? Before, all of the codes used to vary by state. Now, HIPAA mandated that all of the codes be standardized. So we have two wonderful books that are given to us by the American Medical Association. They include procedural and diagnostic codes. It makes it easier for providers to bill a variety of different insurances because all of them use the same standard, and it's easier to bill electronically. Procedure codes are performed usually by physicians, qualified healthcare professionals, and for example, it's like a sleep study or an office visit. So, HCPCS is the Healthcare Common Procedure Coding System. It has 2 levels now. It used to have 3 levels. The first level is the CPT code book. This is the code book that in sleep medicine we use the most. And then HCPCS, the Healthcare Common Procedure Coding System, has a level 2 book, which is also has more codes within it. I'll go into detail about the specific 2. There was a level 3 code book that was varying from state to state, but they got rid of that in an effort to standardize nationwide. Okay, so the CPT code structure, it's a 5-digit system. It's numeric only, and the category 1 has the most typical categories of codes used in sleep centers. So if it starts with a 0 in the 5-digit system, it's anesthetic services. If it's 1 to 6, it's surgical services. 7 radiology, 8 pathology and lab, and 9 is going to be where we spend most of our time, which is going to be the medicine services. There are category 2 codes. Those category 2 codes are tracking codes. They're used for performance measurements. They're not used for billing and coding. They're a 4-digit system that ends with the letter F, and like I said, not used for billing. Category 3 are temporary codes that are used for emerging technology. Within the realm of sleep medicine, we're having, as Dr. Suarez mentioned, actigraphy, which is a growing field. That wearable devices are becoming more and more smart. And I think Apple right now is working on being able to draw an ECG from their Apple Watch device. And as technology continues to grow, the codes are going to have to adopt the new adopt them into the system so that they become primary billing codes. And that's the goal of category 3. Eventually, hopefully, some of these become category 1 codes. So they're 4 digits and they follow with the letter T. So each major section has subsections, it's a very detailed book. It provides information on how to code the particular procedure, the definitions of what each code means, and then instructions for which code to use in which situation. There are unlisted codes if the guidelines if your patient's presentation or the diagnosis doesn't fall within the line of the coding, There are some unlisted codes that are available for use within each subsection, some subsections. There's none that are used for sleep, but there are some in the neurological disorders. So, the modifiers. As I mentioned before, these are things that we typically don't want to use because it then makes it more complicated for insurance companies, and there's a huge variance amongst the different companies and what they cover. These are the two-digit modifiers, which essentially say that the level of service that was performed was either below or different than what is written in the guidelines. So 26 is for only the physician portion of the procedure was performed, so the doctor's portion was performed. TC was that the technical portion of the procedure was performed. And 52 is the one that we never use, which means that less than the complete service or a reduced service was provided. 52 equals denial, for lack of a better term. Different insurers, they accept different modifiers, so like I said, huge variance. It's better not to use them. And then for HCPCS. HCPCS was developed by CMS, the Centers for Medicare and Medicaid Services. These include all of the codes for drugs, DMEs, prosthetics, supplies, and dental services and business services. So DMEs are the durable medical equipment that's used at home. In the sleep medicine realm, we're talking about CPAPs, BiPAPs, the oral application therapy devices. And then there's disposable items in sleep medicine as well that have specific codes. The PAP masks, the tubing, the nasal cushions, and humidifiers, things that you're going to be giving the patient on a regular basis because they go bad. So the level 2 codes, this is also a 5-digit system. It's a letter that's followed by 4 different numbers, and it's divided based on the letters. So E is DMEs, A are the medical and surgical supplies, and there's also administrative codes in there. J is drugs other than chemotherapy. Q, K, and S are temporary procedure codes. So the level 2 has something that's very interesting, is that the patient's body, the particular area in which the patient is getting a service is able to be identified using modifiers. So they can indicate whether it's the left or the right side of the body, what part of the body it is, if it's the hand, which digit on the hand, it's the toe, which digit on the toe was being treated during the procedure. But this is not typically used for sleep services. Modifiers can be interchanged between CPT and HCPCS, but insurance companies, like I said before, it's better to use no modifiers. It's better to use just in general what the codes are. Okay, so CPT codes in sleep medicine, they're usually found in the neurology, neuromuscular procedure code section, and that's within the medical section, the medicine section of the CPT code book. All of our codes, they start with 9. And within the realm of sleep medicine, the codes are 95800 to 95811. So the sleep section includes those guidelines, those specifics as to when to use which code, what are the definitions for each of these codes, and the modifiers that are inside as well. Most of the sleep codes require at least 6 hours of reporting time. So if you don't get 6 hours worth of reporting time, then the modifier 52 is used, and that's when you're at risk for a denial. 95805 is, as Dr. Suarez was talking about, after a sleep study is done, if the patient's at risk for narcolepsy, then MSLTs is performed, and also maintenance of wakefulness tests. 95807 is a sleep study that includes reporting of different channels. The channels that are available are ventilation, respiratory effort, ECG heart rate, oxygen saturation. Dr. Suarez actually went through a much more. There's about 7 or 8 that can be measured. And the billing will also be related to how many of those channels you are testing. So for polysomnography, 85808 is the sleep staging with 1 to 3 of the parameters that we just mentioned. 95810 is typically the one that is billed. It's sleep staging with 4 or more additional parameters. And then 95811 will be for a follow-up. So say you send your patient for polysomnography. They get diagnosed with obstructive sleep apnea. You order CPAP, and then it needs to be titrated. 95811 is the code that you'll use for the titration. Out-of-center sleep studies, I mentioned about actigraphy, 95803. This is a growing field. 95800 and 801 are for unattended sleep studies. Generally, insurances want you to do attended sleep studies. And 95800 is monitoring of the actual sleep time. This is important as well because you need 6 hours. If it's done without 95801, it doesn't include sleep monitoring of time. And if that's the case, it's most likely not going to be paid up by the insurance companies. 95806 is an unattended sleep study with additional recording channels that were mentioned, like before: ECG, respiration, movements, EOG. Okay, so HCPCS has its own codes for out-of-center sleep studies. So G0398 is an unattended sleep study with a minimum of 7 recording channels: EEG, EOG, EMG, ECG, airflow, respiratory effort, and oxygen saturation. G0399 is 4 recording channels with an unattended sleep test. G400 is unattended with 3 channels. So we have DME and medical supplies as well, for PAP devices, for PAP supplies, for humidification devices, and oral appliance therapy. Okay, let's go into the diagnostic code. Why is it important? So the common misconception is that diagnostic coding is not as important as procedure coding. It is really important for a diagnosis to be there, for accurate billing to occur. So without the proper diagnosis, you cannot justify a procedure. So if you order a polysomnography and you don't have the ICD-10 code for obstructive sleep apnea or something to justify the sleep study, likely you'll be denied for the office visit, and you'll be denied for the actual sleep study itself. It's also really important for tracking, because every time an ICD-10 code is used, it's used to track the evolution of the disease. It's used by the nation in order to see what we need to be prepared for in the future, where our resources need to be allocated. Okay, so the diagnosis and diagnostic codes. There's a primary diagnosis. It's the main reason for the patient's visit. This is the first code that you'll use. Likely your patient's going to come in with multiple diagnoses, and I'll show you an example of that at the very end. The primary diagnosis should justify the visit. It should justify any sort of procedure that's performed. The diagnosis codes are codes for the patient's condition. It signifies about the signs and symptoms, and it determines, it's determined by the physician who's performing the procedure, who's ordering the procedure, rather. So obstructive sleep apnea diagnosis justifies a polysomnography. So for diagnostic codes, we have 2 different ones that we use. Everybody usually uses ICD-10. It's the nationwide standard. And there's also the International Classification of Sleep Disorders, which also have more specific diagnostic criteria as well. In the sleep centers, the International Classification of Sleep Disorders is used. ICD-10 is a 7-character alphanumeric code. It starts out with 1 letter and then 2 numbers. Usually there's a period in between it, and then a subcategory, 1 number, and then subclassification of 2 numbers to further explain the manifestation, the location, the severity, and the type of injury of the disease. The alphabet helps us, the extension helps us describe the type of encounter. So this is a lot different than what ICD-9 had. It's so much more specific. Specific in that we can now say the cause, the manifestation of the disease, the location, and the severity. These are things that were not able to be mentioned in ICD-9. This was a very good update. Code locations, manifestations. There's less redundancy. So it documents both the diagnosis and whether the injury has been examined before, and it reduces the administrative burdens because if you're consistently billing for the same thing, you don't know if it's an initial visit or if it's a follow-up, it makes a big difference. It also introduced laterality, meaning that you can say the left or the right side of the body, you can say where specifically the infection is occurring. Substantially increases the amount of information about this diagnosis as I've mentioned to you before. Let's look at an example. So G47 is typically the codes, the ICD-10 codes for sleep disorders. G47.0 is insomnia, 0.3 sleep apnea, 0.4 is narcolepsy and cataplexy. If you go even further, 0.411 is narcolepsy with cataplexy, 419 is narcolepsy without cataplexy. So G47.4, if you were to just use that and try to bill for it, it would deny. If you use G47.41 and you try to bill for that, it would get denied. You need to be as specific as possible when it comes to ICD-10. If it has a 9 in it, in this one it's a bad example, but typically if there's a 9 in it, like F20.9, that usually indicates unspecified. Unspecified is we don't ever use unspecified when we're billing. Unspecified within the inpatient setting will vary it will get you a denial. Within the outpatient setting, it will get you a denial or a prior authorization. So more likely than not, you want to be staying away from it and collecting the data that you need to appropriately diagnose your patient. So there are a couple of different postulates that are within the CPT and the HCPCS code also. That's a term that's used for a code that may require another code that fully describes the disease process that's in place. So G47.14, hypersomnia due to another medical condition. What's the other medical condition? You need to be able to bill for the other medical condition, like a brain tumor, in order for you to get reimbursement from the insurance companies. Code first is the underlying condition that the code is being used as the primary diagnosis. So you need the primary diagnosis first, and then the secondary code, for example, G47.37, which is central sleep apnea in conditions classified elsewhere. Classified elsewhere means that you need to have the ICD-10 code for something like a brainstem lesion in order for you to justify that code. And then there are some codes that include certain conditions, a slew of conditions within one code. That's like F15. Other stimulant-related disorders includes amphetamine-related disorders as well as caffeine. You don't have to do any further coding from that. There are two types of exclusions. Excludes one is mutually exclusive. You can't bill for sleep apnea G47.3 and sleep apnea of a newborn P28.3. You have to be specific about which one you're billing for. They can't be coded together, mutually exclusive. And then the second one is that the code excludes a certain condition. So this is used to identify a diagnosis that's not part of the code or the category code, but it can be reported in addition. So sleep apnea, G47.3, hypersomnia, G47.1, those two things can't occur together. So where are the sleep codes? They're usually in the mental, behavioral, and neurodevelopmental disorders. In F10 to F19, they're mental disorders and behavioral disorders due to psychoactive substance use. For example, F10.182 is alcohol abuse with alcohol-induced sleep disorder. F50 to 59 are behavioral syndromes associated with psychological disturbances and physical factors like F51.01, primary insomnia. And then G40 to 47 are the episodic and the paroxysmal disorders. G47.33, obstructive sleep apnea, pediatric or adult. So F10 to F19 19, these are the alcohol and drug-induced sleep disorders that are found in the mental, behavioral, and developmental disorders section of the chapter. As is mentioned, alcohol, opioids, cannabis, sedatives, hypnotics, and anxiolytics, cocaine, other stimulants, example that I had mentioned before, hallucinogens, nicotine inhalants, and other psychoactive substances. So, sleep disorders that are not due to a known substance or known physiological condition are found in the mental, behavioral, and neurodevelopmental disorders section of the chapter. So F51.0 are insomnias and hypersomnias and parasomnias. So 51 from 0 to 9. Sleep disorder 0.9, not due to a substance or known physiological condition, is billable. So G47 is in the nervous system chapter, and this is where primarily some of the sleep disorders are going to be billed. So we have G47.1 and all of the specifics of the hypersomnias. G47.2 are circadian rhythm sleep disorders. .3, sleep apnea. This is the most common area for billing. 47.4, narcolepsy and cataplexy. Parasomnia is 47.5. 47.6, sleep-related movement disorders. And then codes that are not found within the realm of those breakdowns would be E62, 66.2, morbid severe obesity with alveolar hypoventilation, restless leg syndrome, nocturnal enuresis, primary sleep apnea of the newborn, Cheney-Stokes breathing, and snoring. Okay, I'm going to talk a little bit about E&M codes. Dr. Ahmed, are they bringing the lunches now?
Lunch in the back.
Should I break down? Continue. Okay. Okay. So E&M codes are the CPT codes that are used to describe the services that us doctors provide. They start from the patient's visit with the illness of the injury, the chief complaint. The physician takes the history, gives the physical exam, makes a decision on the course of care, and then decides on any additional tests or procedures that they might need in order to appropriately treat the patient. So 99 is where most of the billing for sleep medicine is going to be found. And within the CPT book, this is such a popular section that it is used. It is found in the front of the book now, so the book is no longer in numeric order. It's the most commonly billed area, so they put it at the front. All right, so in general, E&M codes have a range. For a new patient, 99201 to 205 is the range, and for an established patient, 99211 to 215 are the codes that we use. The higher the code number indicates the higher the level of the service, which indicates the higher level of payment. So the difference between new patient and established patient, you will be able to tell, is the fourth digit. And the code selection is based on all of the documentation that we provide. So the documentation that's listed in the history, in the physical exam, in the assessment plan is primarily where these codes are dictated. Now, E&M codes are found for almost every single procedure that you might be able to think of. Within the hospital setting, consultations, ER visits, critical care visits, within the nursing home, providing in-home services, preventative medicine services, newborn care services, and many, many more. There are several descriptors in E&M codes. the place of the service, which would be office or emergency room within the hospital, content, the extent or level of the service, the amount of history, the physical exam, and the medical decision making, what the nature of the problem is and how severe it is, and time. So Medicare is trying to have doctors bill based off of time. This has its advantages and its disadvantages. The advantage is that the billing becomes much easier, and the documentation that's provided is not as it's used as a supplementary, but primarily if you put in a time and you're billing based off of the time, you will get a payout. The problem is that 10 minutes with one patient does not necessarily equivalent to 10 minutes with another patient. So what this does is it stratifies the data for Medicare, but it doesn't really correlate to the amount of workload that the doctor is using. So if you're part of some of those lobbyist groups that meet for Medicare, I suggest that you lobby against time being used for billing, because it ends up paying us less for the time that we spend with our patients. Guys, food is in the back. Please feel free to grab it. I'll continue talking, if that's okay with you. Try to get you guys out of here so you can enjoy this beautiful Miami weather and the beach that's right over there. So, as I mentioned before, 99201 is a new patient, the 0, and the 99211 is an established patient. That is the major difference. And new or established is defined as if you've seen that patient within 3 years. So it also matters if you're in a group practice and you're referring within your practice. If you're from the same specialty, then the coding is different. So let's say I see a patient, I'm a brain injury neurologist specialist, and I see a patient that's having some seizures and I want to